Good morning, everyone. Thank you for joining us today. I'm really excited to be doing a presentation on group formation and MSOs. Since we do have a small group on this communication, would it be possible for us to just quickly introduce and why you're here so that I can also hone this program in perhaps a little bit more to what some of your needs are? Is that something we can do, Mindy?
Certainly, we can do that. Denise, you want to go first?
Maybe what company you're with and why you've joined today.
Hi, I'm Denise Schneider. I'm the president of the Palm Beach MGMA. For my university urologist group, they're thinking of joining a hospital system. So I wanted to learn a little bit more about that.
Okay, excellent. Thank you.
Naomi, you want to go next? You're on mute.
Hi, that will work. Good morning, everyone. My name is Naomi Manning. I'm the founder and CEO of MedPrac Billing and Practice Solutions. My goal is to develop a physicians group. So I'm here to get all the information that I need to get.
Excellent.
Thank you.
Evan, would you like to go next?
Hi, sure. You can hear me?
Yes.
Hi, I work at Mazars accounting firm. Have a bunch of healthcare clients and don't have a lot of experience with MSOs. So want to brush up, get a little background and try to learn something.
Perfect. We're going to talk a little bit about accounting too today, so we'll be right up your alley.
Then we have Catherine Gill.
Hello, everyone.
Catherine, do you want to do a brief introduction?
Sure.
Oh,
Can you
sure.
guys hear me?
Yes.
Okay. Hi, I'm Catherine, and I am the practice manager for Urologic Physicians and Surgeons, and we are a division of Urology Group of Florida.
Perfect.
And then Matt.
Yes, hi, I'm Matt Gracie with Dana Gracie Risk Strategies, and I'm always interested to hear Cheryl speak because she has such great information, and with so many groups being formed now, we're always trying to keep up with how they come together and so forth. So I'm just loving to get the information. Thank you, Cheryl.
Thank you, Matt. Okay. So again, I'm Cheryl Anders, CEO of Think Big Healthcare Solutions. We have been around since 2009, providing practice management solutions to physicians, nurse practitioners, PAs, and other companies that sit in the healthcare network of our entire division, whether it's ACSs and things like that. We do full practice management. We're going to talk a little bit about some of our services. One of our specialties is group formation, how to bring private practices under a single tax ID. And that's what we're going to look at today. And we're going to talk a little bit about MSOs, and we're going to talk a little bit about MSAs, which is Management Services Agreement, MSOs, Management Service Organizations, of which we are one of. There's a lot of different definitions to those, and we'll dive into that in just a little bit. But first, a couple of quick disclaimers. This material is copyrighted, and the presentation is meant to be a general business presentation. I am not offering legal guidance. I am not offering accounting guidance. What I want to do is share with you some basic business concepts of the things that we see in the industry and what I deal with on a daily basis. Give me 1 second. I'm just going to move this over. Okay. Okay, so group formation. Why do physician practices want to join a group? I never read slides, so you can read yourself, but I'm going to kind of talk about some of the highlights. Essentially, in the changing environment that we are living in today, it is becoming more and more difficult for a single physician group of maybe 1 or 2 physicians or even 3 to be sustainable in the market. I often get phone calls from physicians stating, XYZ insurance is dropping me from my 3 main products. Can you help me? I'm going to lose XYZ revenue. you become much more susceptible to the forces of the market when we as independent entrepreneurs in the community, practicing medicine, cannot really control our reimbursements and cannot really control the business decisions of larger companies like ACOs or insurance companies or hospital systems and other things that can impact the kind of revenue that you're able to generate. So a group formation allows for some entrepreneurship. It also allows for you to have some sustainability because there is power in numbers. Depending on the kind of group that you form, and we're going to talk about two different kinds of groups, the bylaws and the regulations will determine the extent of entrepreneurship that is allowed under that model. In many of the groups where we have physician partners, they do allow for a fair amount of activity that is determined by those physicians in their clinics, whether it's on daily operations, the kinds of staff members they want to have, their hours of location, how they want to handle their expenses at their practice level, and things like that. The business partners, when you form a group under a single tax ID, typically have centralized business functions. Now, not all groups do that, but in the ideal model, you have the efficiencies of having an MSO, which is a medical specialty operation system or a central business office that's handling a lot of the things that most smaller practices sometimes don't even look at. So there is just a wealth of information and a wealth of resources now available to a physician group of 2 when they join into a larger group and become a physician group of 10 or 15 or 20 or more. We're going to talk about that in just a little bit. So here are some of the advantages. We know that we have synergy and power in numbers when a single physician joins to a larger group. We see this throughout the country. Everyone is talking about group formation. Physicians are making groups occur, and then they're selling to venture capitalists or to other companies. And it's just kind of like this gobble up kind of a game, but there's a lot of money in it. We can talk about that at another time. I have my own personal opinions on those things, but what we're really talking about right now isn't about venture capitalist dollars and those kinds of investments. I'm talking about physicians in the market that are looking to come together for sustainability and for some additional opportunities to improve their revenue. So in most of the groups, there is autonomy, but again, it's going to depend on the corporate documents, and we'll get to that. It may improve your contracting and negotiating for better rates and plans, but I can tell you in the last 12 months, it is becoming harder and harder, even for groups of 30 or 40 physicians, to move the needle on getting better contracts from the big players in the markets. However, it can be done, but it's not as easy as it used to be 4 years ago or 10 years ago, even for a larger group, which then equivalates down to what do the onesies and twosies doctors do when they're trying to get a better rate for their practice because they haven't negotiated since 2007 and they haven't seen their contracts since 2005 and their rates are outdated. There are ICD-10 codes that probably aren't even on their contracts that they are billing for today in 2023. So insurance is a big reason why people tend to come together. Also, group purchasing power is a huge one. The cost of medical supplies, being able to take a look at group policies, and Matt can address medical malpractice and other kinds of insurance policies when we're able to bring those things together. It just gives us a better opportunity on that end to try to save some money. And then there's shared management fees. So a lot of physicians are paying for, I know we have an accountant, a bookkeeper, someone to do billing, maybe someone to do compliance. They're paying for different kinds of services out in the market. When you bring an MSO together, you get to have some shared management fees and a lot of resource and wealth and knowledge. Some other ones are also meeting government regulations. This is probably one of the biggest ones out there. Most physicians do not have a compliance program of any kind. And it's very important because CMS states that all practices, regardless of size, should have an active compliance program. So having an active compliance program in place, meeting the OIG standards, looking at your OSHA, your HIPAA, making sure your office is compliant is also one of the opportunities when you form under a group like this, that the resources are there to assist you to bring you to the highest level of practice management. Another very important part that doctors love to hear is that when you join a group, the valuation of your practice increases, because instead of bringing in 1.5 million EBITDA, let's say, you are now part of a group that cumulatively together is bringing in $15 million. You've got all these other partners. So if you were ever to sell to another business entity, your individual value of that practice, instead of being maybe worth 3 times its value, can now be worth 7, 10, or 15 times the value. Now, these are insidious values because obviously you're not selling at the moment, but it's inherent into the value of the group as a whole. In some cases, groups never sell. They're just looking to get bigger and bigger and grow and have more value, but there is an inherent value. So if you were a physician in a group and you were aging out and you wanted to possibly sell your practice to somebody else that was going to stay in this group, your practice still has a higher value. So there's some good positives with that as well. Flexibility in future business dealings. Of course, that's going to come down to corporate documents. We'll talk about that a little bit later. Very big, important one. A new physician is moving to the state of Florida. I get this call all the time. Or a physician is graduating from a program and they call me up and say, can you contract for us with the plans? We want to get on all the plans and we want to get on these hospital systems, et cetera, et cetera. You know, in this day and age, to get someone on contracts, it's a good 30 to 90 days if you're offered a contract. And then it's another 30 to 90 days for that person to be credentialed or enrolled on that plan and live. So that's a good 6 months of time, and time is money and time and revenue. So when you have a group formation like this, oftentimes we can accelerate bringing that physician into a private practice, whether they want to join as a partner or they want to be employed. We now have bypassed a minimum of 3 to 6 months in order to get them on the plans, and we can get them up and running with revenue much, much more quickly. And of course, if there are ancillary services that the group is thinking about doing, then there will be additional revenue for the partners. So the corporate structure, what do these groups look like? This is a big question that I get. There are many, many different kind of business models. I'm just going to take a look at 2 of them. One very briefly, and then one that tends to be what I would call the star level kind of a group formation that is typically happening throughout the country. One of the couple of things that are very important to really consider is you must engage, if you're thinking of doing this, with lawyers who understand state and federal knowledge. Especially if you're going to go out of state, you need them to understand various states and how this would all work. If you're local, and we're just going to talk about Florida now because this is where we are, you need someone who really understands all of the important federal and state regulations, so that when they create the corporate documents, the binding documents that bring you together, that all of these things are addressed. I always suggest we involve accountants because there are tax opportunities in the formation of these groups. So having an accountant represented on this call today is a very important part of what I do when I am bringing together a group formation. And then to seek business experts, you know, to operationalize the legal documents, to bring this whole process together. It is an art and it is a science, and there is a lot of negotiation that goes on between the founding partners of the group, physician partners. There is a lot of conversation that goes into the creation of the documents, and there's a lot of information that goes into how do you recruit and grow a group. You know, at the end of the day, what is the value and why is that value there? So the corporate structure typically looks something like this. These documents can be called different things, but overall, there is a partnership agreement. How do the physician partners come together? And in some of these groups, we have nurse practitioners that are partners and PAs that are partners in these kinds of these groups. Professional services agreement. Not only do you have a partnership, but what is the regulations or the rules that this group wants for the professionals to serve as doctors and providing services? And these documents are not short little quick documents. They can be 40, 50, 60 pages each. This is a lot of legalese terms that go into it. And typically there's some form of a restricted covenant agreement, which actually protects the group. The most interesting part of this is the philosophy, because all the partners have to sign the exact same set of documents. Dr. A cannot say, I don't like this. Can you just carve this out of my professional services agreement? The answer is no, because this is a single tax ID and everyone as a partner, not as an employed physician under this group model, but as a partner, everyone has to be equal and the same. So you want a group of like-minded providers coming together as the founding members. And then as you grow this group, you want to make sure that you have like-minded providers. Why? When you don't have like-minded providers, remember, we are a group in a single tax ID. Everyone needs to be able to agree and agree to disagree. So you want to make sure that you have physicians that practice solid medicine, that you have a process in place to assess those kinds of things, and that in terms of what they're looking for, that they're looking for the same things that the group is looking for. Not everyone is right for every group. There's lots of choices out there of pre-existing groups to choose from. You want to make sure that as a physician joining one of these groups or starting a group formation, that you're doing it with the right subset of people, because it is like a marriage. A business partnership is another word for marriage. It breaks up typically over financial things or because people are upset with each other over some very salient philosophical points. So some of the things that when I go through group formation, I look at when I'm talking to the partners, well, how do you become a partner of this group? Is there a buy-in? What do you do? Who can join this group? Is this a single specialty? Is this a multi-specialty? These things have to be discussed up front. Well, how do you terminate from the group? I'm unhappy. I've been with the group for a year. I don't like being a part of this group. How do you execute a termination agreement? What do your corporate documents state? Are there non-compete clauses? Are there non-compete clauses for other forms of business that you might want to conduct? What happens if you sell the group? And what does that look like? Is it a supermajority that votes on that? And how do you divide shares and who gets what? Partners want to sell their practice individually within the group. They want to exit. I'm aging out. I'm turning 67. I want out. I want to sell my practice. Who can they sell to? Who can't they sell to? Loans. What does that look like on the financial side? Can you take loans? How does that work? The power of the board. Board terms, how long do people sit on the board and things like that become very important. This is just a little sampling of a few of the questions. There's probably 100 behind here. Here's another one that like-minded providers have to think about: ownership of more than one subsidiary under this model. Does the group want to purchase practices, or do they strictly want partners that have practices? You have to determine, how do you share the MSO cost, the cost of running this company? There's multiple formulas out there. We'll talk a little bit about that later. Is the MSO a separate business entity, or is it part of the parent tax ID? Are there restricted covenants? What about non-competes? What about other businesses outside of the main group that are permitted? And how do you determine units and shares? And is there an opportunity to purchase? Some very basic questions. Laundry list can go on, but that would take the whole time that I present for. So this is one model. This model is, I call it the pizza pie model. Okay. So each of the partners have a little practice that is over here in the big pizza pie, and the pizza pie represents the tax ID. Okay. So the big turquoise colored circle is your tax ID, and all these partners are partners in this tax ID circle. And so the government will look at this as one business unit. The partners all have shared risks at all levels. You can actually still employ physicians in this model who are not partners, and the partners have whatever units and shares that their corporate documents allow. So in this model, you actually have some opportunity for some increased risk, and Matt will nod his head, because in this model, if one of the partners has a lawsuit against them, there is no protection against any of the other partners or the tax ID, where all the money is harbored in this particular model, that will become part of a medical malpractice case. Let me just get rid of that. So in this model, if partner A has an issue, it's going to affect everyone else. If partner A has done something wrong, in the hospital and he's getting sued, the chances are that all these partners can be pulled into that suit. Their medical malpractice license insurances will be tapped into depending on how they've set that up. But most importantly, the business entity also has no protection. And this business entity can be set up as an LLP, an LLC, an INC, a PLLC, whatever your tax attorney and or your accountant would claim that they would want you to do. So this is not my favorite model, but it exists out there. This is more of the gold standard. Let me get over there. So this is the gold standard that we typically see today. And back in the day, this has been in practice for many, many, many years and has proved the time test in terms of protecting some levels of security and risk mitigation for physicians that are part of it. So the way that that works is there is a business entity that is set up, an LLP. Typically, I see them as LLPs and LLCs because that offers more security as well. At this highest level, we have a tax ID, human resources, accounting, and contracts all sit up here because the IRS and the federal government are going to look at this entity as one business entity because it is a shared tax ID. Underneath this parent company, and this kind of looks like a spaceship or maybe an octopus, I've been told, we have the individual partners or the clinics. They are subsidiary LLCs of the parent company, which share the same tax ID, which means human resources across the board have to be the same. Accounting principles across the board have to be the same. And the contracts that live up here also are going to be the same contracts that we are going to provide to the subsidiary LLCs, okay? The partner at this practice level does not own his practice. He is a partner of this group, of this parent company, and the parent company owns the subsidiary practice. That is the number one question I get from doctors, but what do you mean I don't own my group? What if I want to leave? Whose patients are they? Again, your bylaws, your corporate documents are going to clearly dictate what that's going to look like. But you cannot take a loan out over here against the tax ID because remember the tax ID sits here. All loans have to be approved at the top of the model. So we have lots of workarounds. We're not going to get into those things at the moment, but that's what happens. So in this particular model, I put myself as an outsourced management company. So we are the MSO for many companies like this, where we supply, and you're going to see all of the different kinds of services that my organization does. We're going to supply all of the infrastructure that handles everything and anything that is non-clinical. We practice no medicine at the MSO level. The practice of medicine happens by physicians and providers at the practice, period. So very, very important to understand that. These are non-clinical services. These are straight business services, and there is no practice of medicine. The practice of medicine happens down at where it belongs by licensed physicians and other providers licensed in the state of Florida. Okay, so let's talk a little bit about the board of directors when you form these. Typically, these are the kinds of things that you see the board of directors determining. What software, what EMR are you going to work on? What digital platforms? What payers do we want contracts with? Right now in several groups, we're in negotiation and the groups have to decide, and you probably hear this all the time. You know, this XYZ group is no longer taking Blue Cross Blue Shield because Blue Cross Blue Shield won't give them what they want. And at midnight on February 28th, you're no longer be able to see your gastroenterologist or your rheumatologist or your urologist or whatever. But what payers? How do you negotiate with those payers? The insurance and benefits for your employees. This also happens typically at the highest level. You do involve committees and things like that. The bank that you're going to choose to handle your financials. Remember, one tax ID, you're going to have banking. And then how do new members join? And these are just a couple of many, many things that I deal with when I sit at the board of directors meeting and I am reporting. But these are some of the bigger decisions that happen that typically are not going to happen at the practice level. Now, there are groups out there that will allow multiple electronic medical records. That is something that has to be worked out based off of the way that revenue cycle happens. It has a lot more to do with billing than anything else. But again, all of these things are doable. You just have to have the right solution in place. But again, the software is going to be determined. We want one EMR, one PMR, 3 PMRs, 2 EMRs, you name it. I've seen it all. Decisions that typically happen at the partners level also is determined very strongly by what your corporate documents are. So in many groups that are formed this way that are not owned by venture capitalists, we're going to be talking about doctors still have the choice to pick the hours that they work. They don't have to call up the corporate office and say, hey, I'm taking 3 weeks off to go to Europe. They're going to still run their practices in their microcosm, following the bylaws and the rules that we have set into place. They still get to decide who they want to hire, who they want to fire. They still get to do purchasing decisions for their practice. I want to use this product and not that product. They should have that flexibility as a partner. Daily operations for the actual clinic being open. I want to open on Saturdays. We want to provide after hour services. Other partners may not, but at your particular clinic where you're a partner, you may want to offer those. Individual relationships that you desire to have with other facilities. I want to be on staff at a hospital, or where you should be referring your patients. Very important part. Physicians need to determine where they want to refer patients to. That is, in their best clinical judgment, they're going to send a patient to someone that they are comfortable with. None of that is managed by anyone else except that individual physician who is responsible for that patient's life, well-being, and their outcome. Marketing tends to happen also at the practice level. Sometimes we'll see things happen at a higher level. And typically in these models, it's an eat what you heal model. So you're not going to be employed where you're getting a salary. You are a partner in a group. It is the eat what you heal model, similar to what physicians right now that are in independent practices. If you take off 3 weeks, guess what's going to happen in 6 to 8 weeks from now? Your revenue is going to dip down, and you're going to need to be able to adjust that so that you can pay your bills, those kinds of things. Management services, this is just a very quick overview. These are all the kinds of services that we support to groups, to individual practices, startups, whatever the case may be. We just do it at a much, much greater level and with much, much more awareness to risk mitigation. Because instead of just dealing with one practice and a subgroup of physicians, I have 15 partners that were all in practice independently that are coming together. And guess what everyone does? They do everything differently. I now have to create a platform so that everyone does things the same way, so that we decrease risk, because everything in the MSO is really about risk mitigation and making sure we're collecting the money and that we're taking care and servicing each of the partners, each of the practices. Where I typically see groups go downhill is when the management services is not structured appropriately. People can't get their core team members on the phone to solve problems in the office in real time. You have a patient in front of you who needs something. The clinic does not have the answer. They need to get a higher level answer. So service excellence trumps everything that we do in our organization. We only exist because we take care of physician practices. That is my bread and butter. That is all that I do. And that is what my team is trained on. Whoops, sorry about that. So you can see there's a huge array: contracting, credentialing, maintenance on credentials, daily operational support, EMR management, EMR go live, chart audits, compliance, risk mitigation, taking care of all those insurance policies, renewals on medical malpractice, making sure that they get their compliance CMEs in if they need to renew that to get a discount on their medical malpractice, human resources, 401k, creating a 401k, rolling that out, workers' comp, payroll, audits, daily support, onboarding, OSHA, HIPAA, compliance, just in general, making sure people understand it. All of those things are going to come through here. And that's what we do. And these are the basic things that you would find in a company that's going to provide these services. Why does the MSO exist? Okay. So an MSO exists to consolidate business functions of the practice and create economies of scale. There are some groups out there where they're still doing individual billing out of the practice locations. I still see things where there's discrepancies in HR and things like that. But when you form under a single tax ID, the whole idea is to save money and to provide higher level understanding of the practice of medicine. And so you're going to consolidate those business functions and roll those into your business office, whether your business office is internal to your group or whether you're part of another company. It really doesn't matter. It provides the business knowledge and resources that a single doc couldn't afford on their own. Oftentimes, I get calls from single doctors and their first response to me is, oh, I can't afford you. And I'm going, yes, you can. We are very scalable, and we do that for a purpose because typically it's the smaller groups that need the help more than some of these larger groups that have more resources to invest in more staff members and team members in order to run compliantly, in order to be able to provide the kinds of things that they need. So those are some of the reasons why. And then depending on the model of the MSO, MSOs can also provide business revenue stream. What does that really translate into? That means that the owners of the MSO, if it's owned by, say, the certain partners, and a lot of times what I see founding partners own the MSO. It's a separate tax ID than the parent company. The MSO can be in the parent company, but it's a separate tax ID from the parent company, and they're getting a percentage of net revenue off of all of the partners. The one thing that I typically find is that doctors don't like when other doctors make money off of them. Sometimes these models don't work very well, but there are plenty of those out there as well. Every day at the MSO, this is everyday life is just, it's running a single practice on steroids is essentially how I can put that, because everything becomes amplified. And because you're not physically in everyone's location, you've got to be able to make sure that everyone is still on board and doing the same thing. So every day at the MSO, we're looking at the experience of my team. Who do I have? What do I need? What do we need more of? We're looking at, for the businesses, in-house, outsource. We happen to be an outsourced MSO. We are white gloved into several organizations where we have started these practices up and we run them for them. Cost versus services. So again, service excellence. We do not cut any corners when we provide service excellence, because the day that we stop providing service to a doctor that needs me after hours, or the CFO or somebody in billing, is the day that you have very unhappy people, and it creates a lot of stress within the organization, and it just means that you're not doing your job. We are in a service industry. Everyone on this phone is about service, service, service. We don't create iPhones. We don't create products. We are here to service and make sure that people are doing things correctly. The challenge I think that all practices have right now, and in multiple industries as well, is recruiting and maintaining talent. Find your talent, keep them, pay them well, figure out how they can be a part of the solution and what they need in order to stay in your organization, providing top-notch service. I spoke a little bit about managing from afar. That's always a challenge, but all day long, once we have built up trust with those practices and sound relationships, managing from afar is not all that difficult. Having set policies and procedures, but only create policies, procedures, and protocols if you're going to follow them. If you create policies, procedures, and protocols and you don't follow them, that is worse. So decide on what's important that you're expecting everyone to follow and share that information. Always have checks and balances in place throughout your organization, not only in the MSO corporate infrastructure, but also within the physician practices. And we do this anyway in 1 or 2 or 3 or a group of 10 physicians, but having checks and balances in place becomes escalated when you're dealing with 30 or 40 practices. Tap into digital, tap into AI, see what makes sense for your practice, know your analytics. I am a major report crazy person. Analytics tell me everything of what's going on a daily basis. I can log on and take a look at someone's schedule, and I know in 2 seconds what's happening in that office. I can take a look at what their payer mix is. I can tell you from the phone calls that are coming in and missed calls, the lost business. So when I sit down with a partner, I can go into so many different benchmarks that can help them better manage their clinic to improve their revenue. Because why do people join these groups? The doctors are looking to join because they want to improve revenue. They want sustainability. So it's always coming down to that. It's our job to take care of everything else, risk mitigation, education, all of that other things. Real estate management. How are you dealing with your leases? How are your renewals? Is there an opportunity to save money on those? Now, an MSO is not a real estate agency, but you want to partner with and look for people that can help you do those things. And of course, vendors, the purchasing and supply chain, that is on an ongoing daily basis, especially I think the number 1 call I get right now is for lidocaine and lidocaine with epi, because there's a shortage on the market. It used to be getting masks and gloves during COVID. How can we get these items into our practice? We can't practice without these things. That becomes our responsibility to solve these problems, because that's all we do all day, every day, and MSO is here to solve problems. MSA contracts. So there's a lot of different terms that go into MSA contracts. An MSA contract is a service agreement. So it is a managed services agreement. In the world of venture capitalists, they use these MSA contracts so that way they are in a relationship, and it depends on the state. So this is a little bit different than what we're just talking about, but you're going to hear this. So I want to just kind of explain it at the lowest level term that I can possibly do it at, where they actually, this practice has joined this company, this MSO that has these MSA contracts, and this is not what we do, that does not allow that practice to do anything else except survive. So the legal documentation is written specifically that that practice is not owned by this MSA, but their contract doesn't allow them. It mitigates their ability to do anything outside of any other system. And so they're tied legally to this company that is going to manage them and provide these services under their company clause. Typically an MSA contract, when we talk about it in these terms, it's a contract between a medical practice and an MSO. If they're looking to have an MSO that's a separate tax ID, even if it's owned by the same physicians, you still have to have a business relationship between what's going on in the MSO to the actual partners group. If the MSO exists in the tax ID, you don't need a contract because it's part of the tax ID. Again, as a management company, you have to be following all the state and federal regulations in every state that you function and operate. You need to understand the corporate practice of medicine. The CPOM is that physicians and providers practice medicine. In my company, nobody practices medicine. No one has anything to do with that level of patient. That all goes back to the providers to do the right thing. You need to understand fee splitting as well. So when you set up your contracts, if you are looking to be an MSO or provide additional services, and I know we have someone from billing on here, there is no fee splitting. There is no self-referral marketing. You're going to follow Stark, Sunshine, all the anti-kickback. You need to be very, very business savvy. And within that, you align yourselves with phenomenal lawyers. You align yourselves with really good accountants who understand physician practices. You align yourself with people like Matt, who's going to help you with your liability insurances. I'm not going to get into all the particulars, but there's multiple layers of different kinds of insurance that are needed when you form these groups. So is there still a need for group formation? Yes, I am probably actively involved with 3 or 4 different specialties right now, working with their legal to put together a model of group formation. There are plenty of smaller groups that want to turn into bigger groups. There are plenty of single physicians or physicians that want to form a multi-specialty group. There's always opportunities to do that. I want to open it up for some discussion, give a couple more minutes because I know we're coming close to the 1 o'clock hour. And I'm here to answer questions for y'all. Oh, last slide. Hold on. I do have one more slide. Sorry. And this is who we are. These are some of the things that we do. Not everything, but kind of gives you an understanding of what Think Big does, what we've been doing for the last decade or so. Yes, I see a question. I see a hand raised. How do I do that? Yes.
Naomi. Yes, Cheryl, my question is, you did mention something about multi-specialty or single specialty.
I'm sorry.
I'm gearing to become an MSO. I'm new to all of this, but that is my ultimate goal, is to become an MSO for providers. Would you suggest a multi-specialty to begin with or a single specialty? 1, 2, which one have you found easier to maintain as a new MSO?
So it has nothing to do with specialties, multi or single. It has to do with the partners you're bringing together. So it has to do with the doctors that want to form a group. Then honestly, for you, Naomi, it's how do you service this group? What is your area of expertise? Do you have people in place to provide all these services at the highest level? Because you are now you have a huge responsibility to make sure you're doing all of these things for this group, because that is typically what you're going to be doing. So really the question is you have to internalize it and ask it back to yourself. What resources do you have? It's a big financial commitment to bring on teams to do these things. We're actually outsourced to other MSOs. Other MSOs call us to do very certain specific functions for them. So throughout the country, I may not be the main MSO, but I am an outsourced entity to provide a variety of these services that they know that we do, and we do really, really well. But it has to do with the doctors you're engaging with. That would be how I would judge whether or not you're going to be able to get this off the ground.
Okay, thank you.
My pleasure.
Cheryl, I have a question. Are you seeing mostly private equity driving the formations, or are you still seeing really just doctors trying to survive with all the compliance issues and billing issues and so forth?
So we see a lot of private equity out there where they're buying practices, essentially. Some of the private equity firms are bringing on partnerships. But eventually what really is going on with private equity is they're selling off. So you might be a partner for the first 2 years. And then, private equity's goal is they bought you they've engaged you, or you came on for X, and then they're going to go and sell you to the next company, and then you become employed. What happens then is there's fallout. Those doctors that don't want to pivot or stay with, and depending on their non-compete, if they have to, if it's from every clinic, or they have to move states, or, get a clinic on the moon because every state is taken and there's no place for them to practice. The fallout sometimes winds up in other kinds of group formation where I get contacted to say, hey, can you help me start my private practice? I have a call later today. That's exactly what's going on. The group that this doctor was with as a partner came on board as a partner. It's being sold. He doesn't want to sell. He doesn't want to be employed. He doesn't want to be under an RVU model. And he wants to go out on his own. And he's talking about forming his own group because he has other friends that don't want to do this. How can I help them? Because they only want to be a physician-owned group in the market. So I see both, Matt. Obviously, the money of selling your practice to private equity, which means you're not a partner in a group. When you sell to private equity, when you hear all these groups that are selling, you are selling your practice to private equity. And then the physician then is an employee. Maybe they have some ownership in stocks and other options in there. But private equity firms have MSOs. And, we work for some of these companies because they outsource to us, because a lot of them have never been in the field of healthcare and they don't necessarily understand or know what they're doing. So we work for some of these companies. We're sought after. I get calls all the time about wanting to be bought out by private equity. So, I'm not ready to sell. So if you're listening to this on the YouTube, it's not, that's not really what I'm looking to do at this moment. Really, it's a mixed bag.
Got it. And with the discussions about doing away with non-competes, I would think it would, if that happens at a federal level, it would just open the marketplace for you, and the demand for your MSO services will just skyrocket, I would believe.
It would be nice to see, these non-competes are so unfair to physicians that really didn't look at their contracts well, or felt they didn't have a choice. What I do see a trend is a lot of the doctors that are finishing up their fellowships and they're leaving their programs and they want to go out on their own. That's where, if you don't have the revenue to start a practice in this day and age, and it is difficult to contract right now, to get new contracts, especially for physicians that are not in state or have been on the plans, it becomes a catch-22 where they almost have to be employed. And then they have to choose, where do they become employed? So I spend a lot of time working with small groups, with doctors that are peeling off of a larger group or moving to the state, and helping them with some of the groups that we manage here in South Florida. For those here, we work throughout the country. We're national, so our reach goes all the way to California and to many, many states in between, up and down. But I got into this to help physicians be sustainable. I left a job in the hospital side of healthcare to really work with physician practices to help them do a better job managing their practices and ultimately taking better care of their patients. Because if a practice is successful, they have more money to put back into the care of their patients. And that's really what it is. I'm a nurse by background, so at the center of our model sits the patient. And if we can make that physician more successful in caring for his patients and have a practice where he can do that, then I solved a problem. And that's what keeps me going in our industry. That's a little crazy at times, but I love it. So.
Excellent.
Cheryl,
Thank you.
can I ask a question?
Of course.
So I think you touched on this before. If the MSO is part of the group and the tax ID and all that, they're getting, typically they get percent of fees. And then,
It depends on the model.
okay, is that the more prevalent model or no?
I typically see a percentage of net revenue as a fee structure. And I've seen some of these fee structures in double digits these days. Why? The cost of running MSOs, very, very expensive to have good talent on your team. Internally, externally, doesn't matter. Just in general, running a practice, an MA that used to make, $13 an hour is getting $18 an hour now or more. Why? Supply and demand. Some models, and I have some groups that have unique models. Of course, I'm not allowed to share them, but there is not a percentage of net. It's based off of multiple other modalities that we have worked out. And actually, when more physicians join, the cost of covering the cost of that MSO actually goes down, typically to a certain extent and to a certain point. So you can be as creative as you want when the partners are going through these solutions. And that is, if you remember that one slide where there was a pink line about the like-minded providers, what is that formula of how the partners are going to pay for services that are rendered outside of their practice? Because that's what the MSO is, services outside of their practice. They have to cover their practice as a partner in a group. But what happens at the higher level? And that's really where the interesting conversation goes. These groups can take up to a year or more to form, depending on Naomi. So listen to this. It's not a quick, easy fix to necessarily get this going, depending on how many partners are going to join the group. But you have to be able to figure out what is good for everyone from the beginning. And that is difficult at times, depending on who you have to work with.
And so if they outsource to you, do you have different ways to structure your fees as well, or you have a single model you use to charge for the
Multiple
service?
ways. We work in multiple ways with different kinds of practices, from a group of two, a single physician, someone who's struggling. So normally, and not outside of group formation, but normally my typical call is, Cheryl, I used to be, getting 60 to 80% on my dollar. I can't even make payroll anymore. Can you help me? But I can't afford you. That's a typical call of what happens when physicians are not paying attention to their revenue cycle and their cash flow and things like that. We work on all different levels. So I do not turn people away. If they're a good physician and they want to do the right thing and they're going to be compliant, we will work with them to figure out how we can help them be sustainable. In terms of group formation, same thing. We work in multiple different ways. And that's part of being sustainable as my own company. I have to figure out what model works in order for my organization to grow and to extend our services further and more.
Do we have any other questions?
Well, thank you, everyone. I really appreciate your time on the phone. If you call that phone number on there, you can easily get to me. That will ring to my phone. That's my direct line in the office. And our office is here in Wellington. So if anyone has questions or want to talk to me afterwards, feel free to connect with me.
Thank you, Cheryl. That was very informative. I learned a lot of stuff today.
My pleasure, everyone. Have a great rest of your day.
Thanks,
Thanks,
Cheryl.
everyone.
That was great.
Thanks for
Cheryl.
attending.
Thank
Bye-bye.
you.
Thanks.
Thank you.
Bye.